Okay, next it's my pleasure to welcome Tessa Le Large to the stage. Tessa is the current HPB Fellow at the Royal Surrey. She completed her surgical training in Amsterdam and undertook a research fellowship at Columbia University. She was awarded her PhD in 2021. She has ongoing postdoctoral commitments in Amsterdam, where her research interests include translational research of biomarkers and novel treatments in periampullary tumours. Thank you, Tessa.
Thank you for the introduction, and thank you for the invitation. I'll focus my talk a little bit more about training in residency, because I know the fellowships are ongoing, but there is a lot of robotics already everywhere. So you actually will see quite a lot already during your residency. And the problem is, how do you get into the console while you're a resident? So I was going to try to explain a little bit what we do in large volume centers, in my case, in the Netherlands. I don't have any disclosures. So the residency in the Netherlands is a little bit differently set up. So we do 6 years of training, of which actually 4 years are full general, which includes trauma, orthopedics, vascular surgery. So it's quite broad. And we do a lot of minimally invasive. Open surgery is really not the standard anymore. So a lot of laparoscopic training during the first 4 years already. And then we have 2 years of subspecialization. So the Netherlands is not that big, but we have about 100 hospitals. And of course, you can imagine not all these hospitals actually have the robot. So I was trained in 2 hospitals, one a more regional hospital where we don't have any robot, and they might get a robot in the short term. But I was also trained for 1 year in Amsterdam, where obviously we are quite a large volume center. And like I said, we are talking about that laparoscopy might be dead in the short time, as discussed before, but I actually think even in the Netherlands, only a third of the hospitals have access to the robot, and not all these hospitals actually are through their full implementation phase. So they cannot train us as residents even to move forward. So if you look at this map, you might be lucky to be in a robotic center, but it could also be that you actually don't touch upon the robot in those 6 years of training. So what we do have in the Netherlands, and I think we don't have that here in the UK, is that there is a robot curriculum that is available for everybody, which consists of all the normal training. So that means you have the online modules, you're being taught in bedside assisting if you want to, through like a short rotation in one of the higher volume centers. And I think one of the outstanding things that we do have is we have access to do a robotic training in Belgium, which is part of our residency. So if you're interested in robotic surgery, all residents actually can go through either of the 2 centers where we can train and have a 2-day course, either in Orsay or in the Amsterdam Skills Center, to learn to dock, to do small procedures, to get really a grip of the robot, even if you're in a center that doesn't have any robot at all. So at least every resident will have the ability to at least access the robot once. So I think that's quite extraordinary and not cheap, I will have to say. And then, of course, if you want to continue with the robotic training, you do have to get into the console. So this is me in the console. I'm doing some suturing in the biolab. But as I said, not all people are in the high volume center. And even if you are in a high volume center, it doesn't mean that as a resident, you're suddenly doing lots of surgeries on the console yourself. I think you just said it, 2 years of assisting. I think I did probably 1 year full-time assisting in the robot, and that's just what it is, because the robot is just, as discussed, a tool for complex cases as well. So what can we do? I think all of us will spend loads and loads of time with all these different tools that we can use. Twitter. I spend a lot of time on YouTube looking for videos of some people that are actually here in this crowd as well. And of course, the intuitive possibility to look back on your own surgeries is a great tool to learn. There's a lot of studies done to say, like, how important is this sim for trainees? And I was actually part of this study from Mark Besselink in Amsterdam, where we were a robot novice. And then if you do actually do the sim training, you do get better. You don't squeeze the tissues as much if you would just start without any sim training. And the same was also discussed by our American colleagues, that actually there is significant technical improvement if you would start out with the sim training first. And I think that's something that we as residents might not always want to think about, and even as a fellow, but I think it's really important, and it really shows that we can improve much quicker I know that laparoscopy is not as might not be as important in the future, but I do feel like all my training that I had with minimally invasive, even colectomies, that is skills that I can use later on in any of the robot surgeries that I do, because the feeling of how you can turn something around or what the distance are, all these things are learned with laparoscopy as well. So if you then transfer that to robotic training, I think that's really useful. And even in a systematic review, they showed that your learning curve will be much quicker if you already are advanced in laparoscopic training. And I think one of the more important things that we should touch upon is that if you're in a high volume center and if you're in a residency, we know now that every new generation of people who are actually training on the robot, they get better and quicker and faster, which means that we as trainees are also getting quicker and faster to a point where we become independent surgeons. So what are the benefits of this large volume training? So I spent more than 1.5 years in Amsterdam. So if you're a high volume, of course, there is a lot of caseload. So there are many cases that you'll see. I'm a short person in the middle. Obviously, the Dutch people are much taller than everybody here in the UK, I feel. So we're much more equal level. Yeah, what we see is there's more complicated cases. So you see really variants of things. And of course, the best thing of being in a high volume center is that your mentors are really proctoring other people. So what we have in Amsterdam, for example, is that a lot of people come to visit us. And I know the robotic Whipple, no, I cannot do it, but I do know all the steps because they're always explained every surgery again to everybody who's visiting. So you do learn a lot from that if you're not sleeping through the surgery while you're assisting. So you really have to say it, like make use of the fact that you're in this high volume center, because all this proctoring, that's something that I try to take with me also now in my fellowship. There are some downsides, I won't lie. Being a resident in a high volume center is not always sunshine. As said, lots and lots of bedside assisting, or even second bedside assisting if there's a second surgeon being on the bedside. Then again, a large volume means there's also some time pressure on caseloads. So we need to get more cases done. So there's not always time to spend a lot of time training other people. And complicated cases also mean it's not a resident or a fellowship case. So I think these are things that are always a bit complicated in such a place. And of course, high volume also means, in the Netherlands at least, I know you guys know us, but the Dutch Pancreatic Cancer Group always has a lot of trials. And I think trial cases are not always the cases also for training. So those are things that will hamper any learning in robotic surgery if you're a resident. So what are some tips and tricks? I figured that might be useful also for people who are actually thinking about training their residents or their fellows more in robotics. We discussed as well, assisting is really important. I think what I mean with don't just sleep, actively join. The robot has 4 arms, but I try to be my 5th arm with assisting, because that really helps out for your own thought process of what the next step is going to be. And you try to rotate out the colon for the Whipples to make everything more easy. So you actively join in the surgery process. I think managing expectation might be important as well. We're not going to do Whipples or major surgery in any time soon. So just try and see the lights in all the small steps that you are learning. Yes, this anatomy that you can see with the robot, it really made my difference as well, that now I finally understand the anatomy way, way better. And I would advise to try to get this robot certificate during residency. And I think in the Netherlands that's feasible because we do assist quite a lot and everybody does the robotic training if they want to in one of the facilities like ORSI. And what mentors can do, I think that's something that we should talk about as well. So some hospitals don't have a dual console, and I think, yes, it's nice if there is a dual console, but I think there's, if you are working together with a trainee for a longer time and you know that this person is not going to do something dangerous, there is space to just swap out and let the trainee be on the console while the surgeon might be bedside or maybe standing behind the trainee to take over if needed, just to make some small progress and small steps. And also don't forget, if you have a dual console, you might have all dual consoles in the world, but you need this third person to be there to sit bedside for you. So that's just something to keep in mind. I think it's really important to keep the trainees motivated as well. So discuss what kind of steps you might make progress on in an upcoming month or in an upcoming procedure, and really discuss what the trainee can do, because of course you don't have to do the full procedure, but any step that you do, maybe mobilizing the bursa, using the vessel sealer ones, all these small things help you to attain more qualities for the future. Review videos together, I think that's a great learning moment as well, because you really see what can be faster, or where you lose your time, or what is dysfunctional, or even going really well. And I think for mentors also, but also for trainees, it's really good to focus on why am I having this instrument in? Why is it in this arm particularly? Because when you start with robotics, you're like, why is this arm here? Why is it positioned in a certain way? When am I swapping out to another instrument? I think these things we do, especially if you're more advanced in robotic surgery, people just go ahead. But as a trainee or as a fellow, as somebody in a fellowship, it's great to learn and hear these things so you can actually understand it a bit better and be more active in this process. So this what, why, when, what it looks for me, very old school. I know we're in like a very advanced futuristic thing. I just write these things down. Where are my ports? Why? What are the steps? How can I get stuff out of the way? So those are things that I think would help, at least for me, to visualize why are we doing certain steps in the robotic surgery to learn and make progress. So to conclude, it's really a changing field, and I hope that as the next generation we have a steeper learning curve. And I think this active observing, not just sitting there, but really thinking why is something happening, and active assisting really helps in progress. And a high volume center, of course, is needed to really attain some skills more quickly, specifically. But I also think that laparoscopy is still quite important to have this baseline, which is needed for the future. And I think discussing steps, what you can do as a trainee is really important, because that keeps you motivated, and then you can see your growth as well. And I think it's really important to remember that every surgical step is progress. So there are always some things to do for a trainee, for a resident or a fellow, and that should just be kept in mind to keep everybody happy.
Thank you very much, Tessa. We do have a bit of time for a couple of questions, if there is anyone on the floor that has a question for Tessa, just while I give them a chance to warm up. It's a bit of a hot topic across Europe at the moment as to whether training programs are now, with the squeeze on training cases from COVID and with robotic surgery, whether training programs are actually creating surgeons at the end of them that are capable of taking up independent practice. What do you think about training? Do you think European programs or even the UK program creates surgeons at the end of training who are ready for independent practice?
I think it's a really difficult topic, because I was taking part of writing the new residency program in the Netherlands as well, because we know that a lot of things are just not feasible anymore with all the changing techniques. You can't do open laparoscopic robot on all the techniques that you want to do, and we are going more towards subspecialization, where you don't have to be independent for everything, but there needs to be a baseline of skill sets that you have to be independent in to be able to qualify as surgeons. If robotics fits in that easily, I think it won't be part of the official regimen in the Netherlands. But if you are interested in it, should be available, because I think because not all hospitals have a robot, and if you don't get any knowledge about it, you'll never know if you'll want to go into this field. So I think it's still important to at least let everybody have that access to it.
Okay, thank you very much. We'll